Welcome to the Epidemiology Prevention of Vaccine Preventable Diseases webinar series, or the Pink Book, presented by the Immunization Services Division at the National Center for Immunization and Respiratory Diseases at the Centers for Disease Control and Prevention from Atlanta, Georgia. I'm Dr. Raymond Strickus, and I'm your moderator for today's session. What you need today for this program is solely an internet connection. All the video and audio should come through the internet connection you are using. The learning objectives for this series include: 1, describe the different forms of immunity. 2, describe the different types of vaccines. 3, for each vaccine preventable disease, identify those for whom routine immunization is recommended. For each vaccine preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice, and implement disease detection and prevention healthcare services such as smoking cessation, weight reduction, diabetes screening, blood pressure screening, most relevant to today, immunization services, to prevent health problems and maintain health. Today's agenda in the Epidemiology Prevention of Vaccine Preventable Diseases webinar series from the Pink Book is General Recommendations Part 1, presented by Dr. Andrew Kroger, a medical officer in the Communication and Education Branch in the Immunization Services Division at the National Center for Immunization and Respiratory Diseases. Regarding continuing education, for CE credit, please go to http://www.cdc.gov/TCE online. For this live course presenting today, the CE credit expires July 11, 2016, just over 1 month from now. For the Enduring Archive course, CE credit expires in June 1st of 2018. When obtaining continuing education, you'll be required to provide a verification code. Watch and listen for the verification code during the course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC does not accept any commercial support. A list of resources for general recommendations will be available at the website below, cdc.gov/ed/pinkbook/pb2.asp. You'll have that website later on. Do you have a question? If you do, please enter your question into the question and answer or QA pod on your screen, and we'll be able to take it, time permitting.
Thank you, Dr. Strickus. It gives me pleasure to present to you today from Atlanta. Today's topic is General Recommendations on Immunization, Part 1. The flow of my presentation will correspond to the second chapter of the 13th edition of Epidemiology and Prevention of Vaccine Preventable Diseases, or Pink Book. The slides that I'm using are similar to the graphics you see in the margins of the Pink Book. The term or concept General Recommendations on Immunization refers to those recommendations that apply to all vaccines. CDC guidance often comes in the form of a single vaccine-specific recommendation, but in practice you have to deal with as many as 16 vaccines given routinely to patients depending on age. We have guidance to address situations commonly encountered in vaccine practice, essentially applicable to all vaccines. CDC publishes this guidance in a Morbidity and Mortality Weekly Report in the Recommendations and Reports series. Since the original publication of the general recommendations in 1976, there have been 8 revisions, the last in 2011, pictured here. The document is 62 pages long with 239 footnotes. We do anticipate posting another revision to this guidance in a few months. CDC generates this guidance based on the deliberations of the Advisory Committee on Immunization Practices, or ACIP, a non-governmental advisory group of 15 members that meets 3 times a year in Atlanta and makes recommendations to CDC. So this MMR is considered not only CDC guidance, but also ACIP recommendations. This is essentially a table of contents list for the ACIP MMWR document. It includes chapters on the timing and spacing of doses, contraindications and precautions, preventing and managing adverse reactions to immunization, vaccine administration, storage and handling, altered immunocompetence, special situations, vaccination records, vaccination programs, and vaccine information sources. The general recommendations on immunization also refers to the second chapter of the Pink Book. And the way the Pink Book is structured is such that there are individual chapters for many of the topics mentioned on the previous slide. For example, vaccine administration and storage and handling of immunobiologics have their own chapter in the Pink Book. So this will allow us to really focus today's presentation in 2 general topic areas, timing and spacing of immunobiologics and contraindications and precautions. And in contraindications and precautions, I will also touch on some special situation issues, vaccination in pregnancy, and immunosuppression. But now let me begin with timing and spacing. So the issues that come up most frequently with respect to the timing and spacing of vaccines are, 1, the interval between a receipt of an antibody-containing blood product and live vaccines; 2, the interval between doses of different vaccines that are not administered simultaneously; and 3, the interval between subsequent doses of the same vaccine. So I'll begin with the first issue, antibody-containing blood products and live vaccines. Now, antibody-containing blood products are those products used to either restore a needed component of blood, like whole blood or packed red blood cells, or products that are used to provide a passive immune response following disease exposure, to provide protection against disease, products like immune globulin. Some of these products have multiple uses. They contain multiple components of the immune system, and antibody is almost always one of these components. This discussion will assist providers with the dilemma of having to use one of these products at the same immunization visit, when a vaccine is due. So the question comes up, can the vaccine be given or can the blood product be given? To understand why this is an issue, remember that this general rule and the fact that vaccines really work very differently depending on whether they are inactivated or live. So we've crafted this general rule that inactivated vaccines are generally not affected by circulating antibody to the antigen. However, live attenuated vaccines might be affected by circulating antibody to the antigen. The antibody in these blood products are not specific to only one antigen. So if passive antibody product is given to someone who has received a live vaccine at the same time, the antibody in the blood product might prevent the live vaccine from replicating. So this is an effectiveness concern for the vaccine. Based on what we know about these products, we can be even more specific and say that this concern is with specific live vaccines, namely measles and varicella containing vaccines. So when giving these products, first note that it takes 2 weeks for the viruses in the MMR and varicella vaccine to replicate. So if measles or varicella containing vaccine is given first, we recommend that providers wait 2 weeks, if feasible, before giving the antibody containing product. After 2 weeks, the vaccine microbe has stopped replicating, and so inhibition is no longer a concern. Often it might not be feasible to wait 2 weeks. What happens if the antibody-containing product was given less than 2 weeks later? We do recommend the vaccine recipient can be tested for immunity or the vaccine can be repeated. Now, if the antibody-containing blood product is given first, providers have to wait an interval before giving your measles or varicella-containing vaccine. The duration of the interval varies by the specific product, and there's a range. The minimum is 3 months, so those are products with the least amount of antibody in them. The way we came up with the intervals is based on the 30-day half-life of a product IG and its effect on the immune response to measles vaccine. So then we extrapolated that to other combinations of products and to measles, mumps, rubella, and varicella vaccine. Now we have tabulated all of these products and all of the intervals in the Pink Book in Appendix A24. The product type is listed on the left-hand column. The dose of IG contained in the product is in the middle column, and the interval before administering measles or varicella containing vaccine is listed in the right-hand column. This is basically a slide that shows the same information. I've just simplified it. I took the middle row out so you just have the product name and the interval. But these intervals are, remember, the intervals are based on the dose of IG. I'm not going to go through every row on this table, but note that some products don't contain any immune globulin, like washed red blood cells. So with no immune globulin at all, there's no antibody, there's no interference with the live vaccine, and so no interval is necessary. So you have 0 months written on the right-hand side. The interval for other products, as mentioned, the range begins at 3 months. It can be as much as 11 months interval. It's really dependent on the concentration of immunoglobulin in the product. The dosage for a single type of product might actually vary even among the specific indications for which it is used. So, for example, you see for intravenous immune globulin, IGIV, a range 7 through 11 months. And so that varies. If you're using IGIV for post-exposure prophylaxis in an immunocompromised recipient, it's actually 8 months. You can, if you look up on the table, you can see it's 6 months for immunocompetent, but for immunocompromised, it's 8 months IGIV. If IVIG is administered for someone with Kawasaki's disease, the interval is actually 11 months. So it's a range based on the dose, which can vary. Why are we applying these spacing rules only to MMR and varicella containing vaccines? Here are some of the reasons why we don't apply these rules for other live vaccines. We don't apply the rule to zoster vaccine because the large amount of varicella zoster virus in the vaccine is thought to be high enough such that it is not affected by any of the antibody contained in the blood product. Yellow fever vaccine, oral typhoid vaccine are exceptions because it's not thought that any antibody-containing blood product, even those pooled from thousands of donors, contains enough antibody to yellow fever or to Salmonella typhi. So it's not thought that the replication of these vaccines would be inhibited if they're given afterwards. With LAIV vaccine, the vaccine itself is constantly undergoing specific changes, antigenic changes, as part of the regulatory choice season by season, so the risk of interference is thought to be lower with LAIV. Finally, for rotavirus vaccine, because the vaccine is administered orally, the site of replication of the vaccine virus is in the GI tract. It's sequestered from the circulation of antibodies in the antibody-containing blood product that might have been administered previously, so we think there's not going to be that problem or a lack of effect of the vaccine. And the rationale probably applies as well to LAIV to some degree, which is also not administered by injection. It's administered intranasally. So now I'm going to move on to the second general timing and spacing issue, and that's the interval between different doses of vaccine. And we're going to discuss the administration of 2 different vaccines, both simultaneous and non-simultaneous. And simultaneous means not necessarily the same exact moment in time, but the same clinic day. Non-simultaneous means a different clinic day. So we have another general rule. The general rule is that all vaccines can be administered simultaneously, the same clinic day, the same visit. Many combinations have been measured and studied, not every possible combination, but generally we are confident that there's little effect on the effectiveness of vaccines given simultaneously. But there are 2 new important exceptions. One is discussed in the General Rex Pink Book chapter, and one is discussed in the pneumococcal Pink Book chapter, because it deals with two different pneumococcal vaccines. Let me discuss the content in the pneumococcal Pink Book chapter first. If there's a need for both the pneumococcal polysaccharide vaccine, PPSV23, and the pneumococcal conjugate vaccine, PCV13, we do recommend that PCV13 has to be administered first and non-simultaneously with PPSV23. The reason for this are studies that were performed in adults receiving these vaccines, which showed that the antibody response to PCV13 was higher in adults 50 years and older if they did not receive PPSV23 first. So we want to optimize the immune response from PCV13. So we recommend it's given first, and we recommend following it up with PPSV23 generally 1 year later. It's primarily an efficacy issue for these vaccines. There also is a higher risk of local reactions if the two vaccines are given simultaneously, and actually within an 8-week interval we see higher rates of local reactions. So that's a secondary concern, that local reactogenicity issue. The other exception to simultaneous administration is co-administration of the Menactra meningococcal conjugate vaccine, or MCV4D, and PCV13 in asplenic persons. Studies that looked at the co-administration of MCV4D and an earlier pneumococcal conjugate vaccine, PCV7, demonstrated a reduced antibody response to 3 of the 7 strains of pneumococcal bacteria. If MCV4D was co-administered with PCV7. Because children with no spleen are at high risk of severe disease from both the pneumococcal and meningococcal bacteria, and the risk is higher because the disease is more common with the pneumococcal bacteria, we therefore, in asplenic persons, we prioritize usage of PCV13 first, and then we recommend MCV4D when the PCV13 series is complete and 4 weeks after the last dose of PCV13. So that's our simultaneous discussion. Now to talk about non-simultaneous administration. So this occurs when providers are deciding to use a vaccine and they have to be aware of other vaccines given recently. And this is relevant specifically with live vaccines. Like the discussion we just had about simultaneous administration, the concern really is the effectiveness of vaccines. It's not a safety issue. And we don't apply this to all live vaccines. We apply it to injected or intranasal live vaccines. We say there needs to be a 4-week minimum interval between the two vaccines. Now this comes from studies in the 1960s that looked at smallpox vaccine and measles vaccine. And if the smallpox vaccine followed the measles vaccine by less than 1 month, there was a reduced immune response to the smallpox vaccine. It was believed to be due to a specific immune component called interferon, was stimulated by the first vaccine and caused an effect on the vaccine given second. There also have been more recent data on this phenomenon observed through cases of breakthrough varicella that occurred when varicella vaccine was given within 1 month after MMR vaccine. It did not occur if MMR vaccine and varicella vaccine were given on the same day. And so, it's not precisely known whether the effect is caused by antibodies or interferon or both. But the key point is that we want you to space the doses by the 4 weeks. We say 4 weeks instead of 1 month. Make sure they're spaced by that amount of time. And if not, the dose that's considered invalid is the vaccine given second. This is our really non-simultaneous vaccine rule. It does not apply to other combinations of vaccines, one live and one inactivated. Two inactivated vaccines, it partially applies based on what I talked about in the previous slide with those two examples, but generally with all other vaccines, there's not a concern about a minimum interval. If two live parenteral or intranasal vaccines are given less than 28 days apart, we say that the second dose is invalid and needs to be repeated. Because of the detrimental effect on the vaccine given second, we say that you should wait to repeat the dose of vaccine until 28 days after the invalid vaccine. We actually think that interferon is operating even with doses of the same live vaccine in sequence. So you really want to make sure that you wait that extra 28 days after the invalid second dose of the two vaccines. The last timing and spacing topic I'm going to discuss is the interval between doses of the same vaccine. There are defined recommended intervals between doses of multi-dose vaccines, and so that's what we're talking about here. A useful general rule is that increasing the interval between doses of a multi-dose vaccine does not diminish the effectiveness of the vaccine. So if doses are late, it does not invalidate doses. We haven't, of course, all variations among all schedules for all vaccines have not been studied, but there have been studies for some vaccines, data for Hep B HPV vaccine that shows no significant difference in antibody titer or even an improved antibody titer when the intervals are extended. You don't want to extend intervals on purpose because that delays protection with the vaccine. But it's good to know, and it's comforting to know, that if the series is delayed, it is not necessary to restart a series. So increasing an interval is not a problem. However, if you decrease the interval between doses of a multi-dose vaccine, this could interfere with the antibody response and protection. So the ideal is to use the intervals recommended by the manufacturer. That's where the studies support use of the vaccine, is based on the recommended ages for each dose. On the other hand, if you happen to administer a dose early, the question arises, is the dose invalid? The general answer is no. In addition to recommended intervals, we've defined minimum intervals. These are intervals that can be used to validate doses that may have been received too early. A list of these intervals is included in Appendix A13 of your pink book shown here. And here's a closer look at that table. As you can see on the table, for every dose of every routine vaccine, we define the recommended age for that dose, the minimum age for that dose, the recommended interval to the next dose, and the minimum interval to the next dose. So in general, you should really not administer vaccine doses at intervals less than the recommended, or definitely not less than the minimum intervals, or earlier than the minimum age. Try to use the recommended ages and intervals. But when can you use these minimum intervals? If you have a child in your office that is behind or lapsed in their series, then ACIP specifically recommends using a catch-up schedule that follows these minimum intervals. These intervals are actually replicated in another CDC document, the ACIP recommended childhood and adolescent schedule. So that's one circumstance where you can use minimums. Another circumstance is with international travel. Someone who's traveling and concerned about measles exposure might choose to have their second dose of MMR vaccine administered 4 weeks after the first dose, even though our routine recommendation for MMR is a first dose at 12 to 15 months and a second dose at 4 years. This can be shortened essentially all the way down to 4 weeks if you want to provide protection for travel. But we really don't want you to do this routinely, to use minimum intervals. I'm going to add, I don't have a slide on this, but I want to add an important point, is that we allow you to even shorten minimum intervals more, and the minimum age younger, an additional 4 days. This is called the grace period. There's an extensive discussion in the Pink Book chapter as well as the General Recs MMWR. The grace period can be used to validate doses already given, or if you happen to have a patient in your office 4 days short of a minimum, you can vaccinate if you fear a missed appointment for rescheduling. So you could use that grace period prospectively as well. But in the absence of an increased risk or the need for this grace period, to maximize protection at the time for which we know the risk for disease is highest, try to use recommended ages for your doses of vaccine. I'm going to now move on to contraindications and precautions. And I would like to give you some general principles of contraindications and precautions, and as mentioned, I'm going to talk about some special categories of patients as well that we often receive questions about. And I want to define a couple terms first. The first term I'll define as a vaccine adverse reaction. An adverse reaction is an extraneous effect caused by a vaccine. Any effect that occurs which is different from the purpose of the vaccine, which is to generate a protective immune response. And a synonym for an adverse reaction is a side effect. Another term is adverse event. This is defined as any medical event which follows a dose of vaccine. Is this different from an adverse reaction? Yes. We're talking about applying these terms to clinical outcomes, and we want to apply the right term at the right time. So an adverse reaction are those outcomes that we know are related to the vaccine. They've been studied prior to licensure by the manufacturer. They've been identified as part of post-licensure safety surveillance. These are really conditions that are adverse reactions are those that we really know based on studies, data, that they're caused by the vaccine. Adverse events we use when we have a clinical outcome that occurs during our surveillance. We don't know if it's caused by the vaccine yet, so we call it an adverse event. And I think it's really important to draw this distinction and define these terms for a couple reasons. One, the Pink Book, we now make this distinction in almost every vaccine-specific chapter. If clinical outcomes that have been described are backed up by data, we'll put it under adverse reaction column, or the subheading. If there are events that have been identified and we're still not sure whether it's caused by the vaccine, you'll typically see it listed under adverse event. And this is a change in the way the Pink Book was organized previously, so new with the 13th edition. And another reason it's important to talk about these conditions is kind of a prelude to talking about contraindications and precautions, because we use contraindications and precautions to screen to avoid these reactions from occurring in the first place. But let me talk now about some vaccine adverse reactions that really are so common that you're probably going to see some of them regardless. One are local reactions. They include pain, swelling, and redness at the site of injection. Most common with inactivated vaccines. Inactivated vaccines can contain, in addition to the antigen, adjuvants, preservative stabilizers, and this can typically cause local reactions. They need to be in there to improve the safety and immunogenicity of the vaccine, but sometimes patients are sensitive to these. Luckily, local reactions are mild and self-limited, and they usually resolve without treatment in a few days. So those are the most common. Next most common type of adverse reaction you might see are systemic symptoms and signs like fever, malaise, and headache. They're very nonspecific, so it can sometimes be challenging to determine if these are actually related to the vaccine. One clue as to whether a systemic reaction might be due to the vaccine is to consider which type of vaccine you've just administered or was administered recently. We know that live attenuated vaccines have to replicate in order to produce immunity. And we know that the reactions that occur following live vaccines can mimic the types of symptoms and signs that you see from the particular vaccine-preventable disease you're preventing with the vaccine. So you'll see, and that makes sense because the vaccine is an attenuated version of the live microbe. That's how that works. The symptoms are milder than the natural disease, but if there are things like fever and rash, they could be reactions to the vaccine. The timing can be a clue as well. If the reaction occurs a specific incubation period following the particular live vaccine, and there's a range based on which type of vaccine we're talking about, it's 3 to 21 days, then it's likely that it's a true vaccine reaction caused by that vaccine, if it occurs at that incubation period. The last type of adverse reaction I'll talk about is the least common, but the most severe, and these are allergic reactions. They can be due to the vaccine antigen or to those other components of the vaccine product. Fortunately, as mentioned, they're rare, and the risk of these reactions occurring are minimized by screening prior to vaccine administration. And so this brings me to the discussion of what conditions are you screening for? And we label some of these conditions in these ways. First, we define a contraindication as a condition in a recipient that greatly increases the chance of a serious adverse event. When you identify a contraindication in a potential vaccine recipient, you should not give a dose to that patient. A precaution, on the other hand, is a condition in a recipient that might increase the chance or severity of the adverse event, or it may compromise the ability of the vaccine to produce immunity. When a precaution exists, the clinician needs to weigh the risk of giving the vaccine versus the risk of withholding a dose of the vaccine and leaving the patient vulnerable to the disease. So I'll reiterate that contraindications and precautions are a category of a condition. They're attributes of conditions in the patient. They're not attributes of the vaccine themselves, conditions identified in the patient during screening. Sometimes contraindications and precautions are temporary conditions, and in these circumstances, it's possible to just delay giving the dose of vaccine. That's the easy circumstance. However, some contraindications and precautions are permanent conditions, and here's a permanent contraindication that applies to all vaccines. If a patient has a severe allergic reaction, for example, anaphylaxis to a prior dose of vaccine or to a vaccine component, this is considered a contraindication and the vaccine should not be given. This is, of course, general guidance for all immunization providers. It is true that some allergists have protocols to administer vaccines to patients who are allergic, but that should only be done in carefully controlled settings where anaphylaxis can be treated. Here are 3 more permanent contraindications. 2 are specific to rotavirus vaccine only. A history of severe combined immunodeficiency disease, or SCID. This is because vaccine-derived rotavirus disease has been observed in patients with this severe immunodeficiency. A history of intussusception is also a contraindication to rotavirus vaccine. Intussusception was associated with rotavirus vaccines used in the 1990s, vaccines that are no longer being used and taken off the market. We're currently investigating this outcome with the current vaccines. The extent of the risk is not specifically known, but what we do know is that intussusception is a gastrointestinal complication that has many different causes. If someone has had a case before, regardless of the cause, they are at risk for it to occur again. Another permanent contraindication is linked to pertussis vaccine, and this is encephalopathy, not due to another identifiable cause, occurring within 7 days of a previous dose of pertussis vaccine. This contraindication derives from our experience with the whole cell pertussis vaccine, which became associated with encephalopathy. This whole cell pertussis vaccine is no longer being used. In addition to the permanent contraindications and precautions, I've listed some other common conditions which serve as contraindications or precautions. The labeling on this table, you can see are indexed by whether we're talking about live vaccines or inactivated vaccines. So speaking generally, the label C means a contraindication, P means a precaution, V means vaccinate if indicated. So we've discussed the first two, allergy to a component and encephalopathy, already. I'm going to talk about pregnancy and immunosuppression in just a minute. Notice that moderate severe acute illness is considered a precaution for both live and attenuated vaccines. If someone has acute, moderate, or severe illness, it's often best to wait until a patient has recovered before vaccinating. Receipt of a recent blood product I've also described already as well. It's considered a precaution for MMR and varicella vaccine, these two live vaccines, because of the interference that I spoke about previously. But recent blood products are not considered contraindications or precautions for inactivated vaccines, so vaccinate if indicated. This is another table in the Pink Book, Appendix A28, that basically borrowed from the Immunization Action Coalition, lists the contraindications and precautions for every vaccine. I'm going to now focus on two conditions specifically, and the first is vaccination, pregnancy. So the risk to a fetus from the vaccination of the mother is primarily theoretical. There's only one vaccine that's ever been demonstrated to injure a fetus, and that's the smallpox vaccine. Since smallpox vaccine is a live vaccine, we have generalized to say that pregnancy is a contraindication for all live vaccines. In general, inactivated vaccines are not a contraindication. They may be administered to pregnant women for whom they are indicated. The exception to this is HPV vaccine. We recommend deferring a dose of HPV vaccine during pregnancy because of a lack of safety and efficacy data for this vaccine in pregnant women. But I'll note that FDA does not label pregnancy as a contraindication, and as highlighted in the adult schedule from CDC, there are no interventions required if the vaccine is given in error to someone who is pregnant. HPV is an inactivated vaccine. Some more discussion of inactivated vaccines in pregnancy. Influenza and Tdap vaccine are specifically recommended during pregnancy because of the additional protection afforded to both mother and fetus in the case of influenza and to the fetus in the case of Tdap. In other circumstances in which a vaccinee might be pregnant, the decision to vaccinate is based on other risk factors for disease. For instance, for hepatitis A, hepatitis B vaccine, and the quadrivalent meningococcal vaccine, the risk factors are what make the vaccine indicated in the first place and therefore drive the decision to vaccinate a pregnant woman. I've already mentioned HPV vaccine should be withheld during pregnancy, even in circumstances where a high-risk condition might exist. There are certain circumstances where PCV13 and Hib might be administered to a pregnant woman, but there's no recommendation to do so from CDC, and these vaccines are not very commonly indicated for pregnant women in any case. Moving on to immunosuppression. Vaccination of immunosuppressed persons is very complicated. There are different degrees of immunosuppression. Generally, live vaccines should not be administered to severely immunosuppressed persons because of the concern that an immunosuppressed host's own immune system will not be able to stop the live vaccine from replicating. There have been instances where severe disease like pneumonia has been caused by vaccine virus. This has been noted in HIV-infected vaccine recipients. Persons with isolated B-cell deficiency, and we're talking about humoral immunodeficiency, can receive varicella vaccine. This is because an effective immune response to the vaccine really is dependent on other components of the immune system which are not lacking. Inactivated vaccines generally are safe to use in immunosuppressed persons, but keep in mind that the response to the vaccine may be decreased. So those are some general principles. When we talk about immunosuppression, what are we talking about? We often classify the types of immunosuppression by specific disease conditions. If the or interventions used to treat conditions, congenital immunodeficiency, leukemia or lymphoma, any type of generalized malignancy can be considered immunosuppressive per se, even in the absence of immunosuppressive medications, but certain medications are immunosuppressive as well. We have cancer therapies, alkylating agents, antimetabolites, and radiation therapy. Those are considered to be immunosuppressive. And I'll make a point, another general principle while I'm talking about these agents. An important principle is that if you're ever in doubt and you are not the provider that prescribed the medication originally, it's always feasible to defer and refer and ask the provider, consult to see if the patient should be considered immunosuppressed or not, because it's not always straightforward, especially with some of these newer classes of immunosuppressive drugs, the immune mediators and immune modulators, and a big category of these are isoantibodies, used not only in cancer therapy, but also for rheumatic diseases and other autoimmune diseases. There's a line of agents, the anti-tumor necrosis factor agents that are used for these types of diseases. The first line of agents licensed, etanercept or Enbrel, infliximab, Remicade, adalimumab, or Humira. You're probably familiar with these. There's now also golimumab or Simponi, certolizumab, Pegol, or Cimzia. These are all anti-tumor necrosis factor agents. So again, if you're not certain, consult with the clinician who prescribed the medication so that you can know whether it's acceptable to defer vaccination or not, or whether it's possible to withhold the medication. Corticosteroids, these are more common and they've been around longer, and so we have a more prescriptive metrics for defining whether someone is immunosuppressed or not. Even though the risk, if you ask an immunologist, it's really tough to get clear guidance about whether an exact dose is immunosuppressive in the context of receipt of a vaccine. It's very complicated. There's not a lot of studies that are done, but we have defined the dose that should be considered a concern, and really it's a cutoff of 20 milligrams or more per day of prednisone for 2 weeks or longer. And then of course there's a dose per weight specific number, 2 milligrams per kilogram for this amount. So that is what we call immunosuppression. It does not apply to, so it's important to realize that it's not only dose or duration, but we're really concerned about systemic steroids, oral or intravenous use. Immunosuppressive label does not apply to aerosol steroids. It doesn't apply to topical or injectable steroids, short courses of steroids, less than 2 weeks long, tapered series, physiologic replacement schedules, like for adrenal insufficiency syndrome. These are all not considered immunosuppressive. Now, if we do consider the corticosteroid dose immunosuppressive or even immunomodulators, we recommend that once the high dose level is stopped or changed, that live vaccine should be delayed. There's a lot of variation on how long you need to wait based on the type of medication that's given. The range is generally 1 to 3 months. I'll make the note that for zoster vaccine, where in most patients there's a well-established host immune response anyway based on past chickenpox infection, we believe a 1 month interval really is adequate for any type of immunosuppressive therapy, with one exception that I will be discussing in a bit. So that basically some important vaccination safety principles. Just to summarize, we're worried about risk of adverse events, replication of the live vaccine virus in immunocompromised persons, so that's the safety side of things. The washout period for most of these medications, if that's what's causing the immunosuppression, generally 3 months, 1 month for high dose steroid use of 2 weeks or more. It's going to be a range of 1 to 3 months for the other immunomodulators. Most of the anti-cancer therapies are 3 months as well. So that's an important. Another general principle, which I haven't discussed yet, household contacts of patients that are immunosuppressed, they need to receive these live vaccines, all vaccines, and including the live vaccines. The benefit of preventing disease in the household contact outweighs the theoretical risk of transmission of the vaccine virus. So that's kind of, safety and efficacy. The one new agent that we need to talk about a lot, I've talked about the anti-tumor necrosis factor inhibitors already. 1 month for most of those. You'll note in the yellow book they draw a distinction between some of them. Etanercept is 1 month, and adalimumab and infliximab, they're now saying 3 months in there. With lymphocyte depleting agents, and this is a new category, rituximab, alemtuzumab are examples of these drugs. We are now recommending a 6-month period before administration of vaccines. And we actually, it's not only a safety issue, it's an effectiveness issue as well. Inactivated vaccines, we don't think that they're going to work if a patient has been on one of these lymphocyte depleting agents. So you really should wait a 6-month period. For influenza, if it's influenza season, you can give the inactivated influenza vaccine, but if you come off the medication after that, you might as well give another dose of inactivated influenza vaccine. Persons with HIV infection are a special category, and this is really the last topic I'm going to discuss today in the interest of time. It's a common type of immunosuppression. It's been extensively studied in the context of vaccine usage and vaccine preventable diseases. It's harder to generalize withholding of vaccines because we know that the complications of the disease is so high, especially measles disease, varicella disease, influenza, and pneumococcal disease in patients with HIV infection, that we actually lower our threshold for giving these live vaccines. In the interest of time, I'm going to refer you to the disease-specific Pink Book chapters, and I've got the information laid out on this table as well. Important things to consider for HIV, I've got a column for asymptomatic. It's not as simple as that. There are actually specific laboratory parameters that vary by vaccine. But the key point is that certain vaccines, like MMR and varicella vaccine, can be administered to persons who have HIV and are not really that immunosuppressed. We want them given because the risk of disease is so high and disease complication. This does not apply to zoster vaccine, which has a high quantity of live vaccine virus. Doesn't apply to LAIV because there's an alternative, the inactivated influenza vaccine. Rotavirus vaccine you can consider in HIV patients. The vaccine virus is considerably attenuated, and often HIV is not even diagnosed at the point in time when rotavirus vaccine is administered. Yellow fever vaccine has very specific defined immunology parameters that define whether you should consider HIV infection a contraindication or not. And of course, note that for symptomatic HIV infection, AIDS, for most vaccines, you should not give live vaccines. So that is the last topic that I'm going to discuss. Before I give the mic back to Dr. Strickis, I would like to ask you a polling question. This is a true or false question. And the statement is, increasing the interval between doses of a multi-dose vaccine series does not diminish the effectiveness of the vaccine. So you can click directly on these choices on your screen, true, false. I see a no vote there. I don't know if that's a choice or not for you, but take 10 seconds to answer. Okay, I think time is up, and we'll try to reveal these answers to you. The correct answer first was true. Increasing the interval between doses of a multi-dose vaccine series does not diminish the effectiveness of the vaccine, and 86.1% of you answered correctly true. Good job. While not every extended interval has been studied, of course, When studies are performed using these extended intervals, there is no decrease in the effectiveness of the vaccine. For some vaccines, like HPV, the immunogenicity is actually higher with extended intervals between the doses. So we, of course, don't recommend that you delay, but protection is not affected if you space these doses out. So if you do happen to fall behind, just restart where you left off. So now I will turn the mic back over.
Thank you very much, Dr. Kroger. Let me give you some continuing education information, and I'll repeat it at the end of the presentation so that you can enter your CE credit after you take the evaluation. The course code for today is capital W, capital C, 2645-060816, which is today's date. Again, the course code is WC2645-060816. The verification code is GEN, capital G, lowercase en, hyphen 2016, and the CE credit for the live course will expire July 11th, 2016. Instructions are available in the resource pod. All right, so let's move to the questions that you've sent us today, and we have some others, but I think we have plenty from the audience today to talk about. Dr. Kroger, there was some concern that you clarify the interval between two live vaccines. First of all, can two live vaccines be given on the same day and counted? That was one question. And then the corollary is, if two live vaccines are given less than 28 days apart, which one should be repeated?
Excellent question. So for the first question, for two different live vaccines, they can be administered simultaneously, and both doses will count. I mentioned when I began to talk about simultaneous vaccination, I gave exceptions, and those exceptions were only two. They're both inactivated vaccine exceptions. So for simultaneous vaccination, two routinely recommended live vaccines can be administered simultaneously, and they both will count. As for the second question, right, when we're talking about non-simultaneous vaccination not simultaneously, but within an interval of 28 days, the vaccines should not be administered. Or I'm sorry, if one live vaccine has been given, you should wait 28 days to give the second. If that second vaccine has already been given and has been given less than 28 days after the first live vaccine, it is the second live vaccine that should be invalidated. There may have been a typo. I'm going to double check to look at the slides on that, but it is the second one that should be invalidated, and that second one needs to be repeated. And the interval to repeat that second vaccine is also 28 days. So you have to wait an additional 28 days beyond the date of the invalid second dose. So you're pushing it later in time. We have concerns about circulating antibody or circulating interferon affecting the dose of live vaccines in this way, and so that's why we recommend pushing that repeat dose 28 days later.
Thank you very much. And there's concern about one of the slides, and we'll check the slides and correct them if there's any error on the slides. There have been some questions about the grace period, and there's several of them. For example, can the grace period be applied to any vaccine? And are there any situations when the grace period cannot be applied?
Excellent question. So the grace period should be applied to really any minimum age or minimum interval that appears on Table 1 of the timing and spacing section of the ACIP's general recommendations on immunization. So what that essentially means is that you can apply the grace period to routinely recommended vaccines, and we're talking about situations, the interval between doses of the same vaccine. So we're not talking about the scenario of two different live vaccines. Don't even think of the grace period in that context. The grace period is thought of in the context of, giving the same, a multi-dose series of the same vaccine. That's where the language appears in the ACIP MMWR General Recs document. So that's kind of where the grace period discussion falls. Now, most providers find it useful, or they find it most useful to use the grace period in circumstances where they're validating doses that have already been given. Applying this 4-day period, 4 days before a minimum age or a minimum interval, and they're able to like count the dose, which is nice that they can do that. But I will add that the original, policy of the grace period was discussed and voted on by ACIP in the forward-looking context when providers actually not planning or forecasting or anything like that, of course, but when the provider is when the patient is standing in front of them and they're wondering if they can use a vaccine. So they haven't given the dose yet, but they want to know if they can. They're in the patient's in the office. And so yes, the grace period was conceived for this purpose, but I'll reiterate that you don't want to use it all the time. If you're worried the patient's not going to come back, if you fear a missed opportunity, non-adherence to a follow-up appointment, that's when you can give the grace period. That's when you can give the vaccine dose if it really is 4 days prior to that minimum cutoff. There's additional really complicated discussion that we're having right now with circumstances where we've allowed, let's say, a good example is like varicella vaccine, where for children 12 years of age and younger, or from 1 year through 12 years of age, the minimum interval between the doses of varicella vaccine is 3 months. But over time, varicella subject matter experts have said, well, you can give that dose actually 1 month apart, 4 weeks apart, if you will count it. We don't want you to do it, but we'll count it. And so our discussions on the grace period have been very complicated, and we've kind of decided that we want to try to limit the use of the 4-day beyond that early allowance, changing 3 months down to 1 month. We don't want to add an additional 4 days on top of that. This is coming in the upcoming general recommendations document, but so I'll stop talking about that now, and you can stay tuned to see that in the document.
Thank you. So just to confirm, then, if one's talking about the 28-day interval between MMR and varicella, one wouldn't apply the grace period there. Is that correct?
Not if we're talking about those specific to vaccines. To put a spin on things, of course, if we are talking about ProQuad, and this also it's good to talk about this actually. This was voted on by ACIP but hasn't been published yet in the general recs. ProQuad is MMRV, the combination product. It doesn't have its own listing in Table 1 of the general recs, but because it has both MMR and varicella components, and because we know that there is some concern about the effect of the varicella component if not given, when these vaccines are given separately, we do want the 3-month versus 1 month. It's between these 2 doses of vaccine. And so when we're talking about grace period in MMRV vaccine, we want to be very, very careful about that. We want to make sure that you have a full 28 days separating these 2 different live vaccines. Don't use 24 days. Don't separate 4 more days when you're using any kind of vaccine that has MMR or varicella in it. So that would be inclusive of MMRV, which many people consider one vaccine because it is. But there you also cannot use the grace period.
Okay, thank you. Could you define or offer examples of moderate to severe illness in thinking about precautions to vaccination?
Right, so this is not specifically defined in the general recs, or I'm not sure if it's defined anywhere in a vaccine-specific MMWR document, but there are certain conventions that are used. We typically we don't define, but we talk about mild, moderate, severe. Mild is, what you would think of as illness that you're aware of, but doesn't really interfere with the activities of daily living. Moderate would interfere with activities of daily living, and severe is, something that makes you bedridden. So that's not a specific definition by any means, but that is a convention that is often used. Let me add that we really want to give clinicians some leverage here and some deference to make a decision as to whether they think their patient is mildly ill, moderately ill, or severely ill. So it really is up to you as the provider to make that determination. And just to clarify, the precaution for vaccines is moderate or severe acute illness. You can wait until a patient is better before giving any vaccine. That's definitely a reasonable thing to do. The term acute is an important part of that definition as well, because there are many illnesses that are, serious illnesses that are stable over time. They're not considered severe, but they're considered, concerning. And if it's not really acute illness, there are many circumstances where you definitely do want to give a vaccine to those patients when the illness is not going to go away, so that you also prevent the complications of a vaccine preventable disease. So.
Thank you. We're going to do 2 or 3 more questions, given it's near the top of the hour. If the questions we don't answer, we will put answers on our website as best we can within a week or 2 of this program. Dr. Kroger, you talked about needing to separate Menactra and pneumococcal conjugate vaccine in high-risk children. Is that issue also true of high-risk adults who haven't received either vaccine and need to receive those vaccines?
So that's actually, there's 2 components to that question, actually. So the meningococcal specific recommendations discuss the need to separate Menactra and pneumococcal conjugate vaccine, PCV13, in high-risk patients. A lot of the discussion in the vaccine-specific document reads like it's specific to children. And we have talked to the meningococcal subject matter experts, and they have said that it would probably be prudent to apply that separation to adults that have asplenia as well. The recommendation only applies to Menactra brand of meningococcal conjugate vaccine, quadrivalent meningococcal conjugate vaccine. But it should apply to adult asplenics equally to child asplenics. The second half of that question, the meningococcal recs also suggest that the separation rule applies to other conditions beyond asplenia, and we've asked the subject matter experts about this as well, and they have told us that really it's asplenia that we're concerned about, the risk in which the risk of pneumococcal infection is so high that we know the effect on the dose is what it is when these 2 vaccines are given simultaneously or less than 4 weeks apart. Although of course the data come from PCV7, but anyway, we've limited the recommendation to asplenics. There's some language in the recs that seem to broaden it beyond that, but we don't recommend the separation to other groups besides asplenics.
Okay, thank you very much. Could you comment on how long after receiving any live vaccine a woman can try to become pregnant?
Wonderful question. Many package inserts say 3 months, but ACIP has made an off-label recommendation based on their knowledge of risks. Really, the risk is theoretical only. The only example of a vaccine that we have is smallpox vaccine that we know causes damage to a fetus. Because of the risk of disease that can exist in pregnant women and the need to protect with vaccines, as well as the fact that risk is really only theoretical. These are attenuated, and in live vaccines are only attenuated microbes. We do recommend a 4-week as opposed to a 3-month. So women should avoid conception 4 weeks after receiving a dose of live vaccine. And of course, once they are pregnant, then it's a contraindication and they should not receive the live vaccine until completion of the pregnancy.
Okay, there were several questions on the same theme of precautions, if any, for vaccinated persons who are in contact with immunocompromised persons such immunocompromised that they can't receive live vaccines themselves, can those people, healthy people, their family members or contacts, come into contact with them following any live vaccine? The specific question was zoster vaccine. Can you comment on that?
Yes. So the general recommendation is that contacts of household persons who are immunosuppressed, their healthy contacts, their immunocompetent contacts should receive vaccines, including live vaccines. It will prevent the disease, and the disease carries a higher risk of complications to the immunocompromised household contact compared to the vaccine. There is one additional consideration that we do make in the context, well, there's a few, but the one, I'll start with varicella vaccine. If someone receives varicella vaccine and they have an immunocompromised household contact, and the vaccinee then develops a rash, we do recommend that they avoid contact with that household contact, with the household contact that's immunosuppressed, because we really think that the transmission is limited to transmission from a rash. Okay, so there's not transmission from the respiratory route, and this applies to varicella vaccine. For the other live vaccines, including shingles vaccine, we don't really make the same consideration. We don't have any evidence of transmission from shingles vaccine rashes. We don't even have a lot of evidence of shingles vaccine associated rashes occurring following vaccination. When rashes occur following, if they occur following shingles vaccine, we would expect such rashes to be localized because the disease itself is localized, and it can be covered up in that circumstance, and we're comfortable with that. We want those patients that have immunosuppressed contacts to receive the vaccine. I can talk about rotavirus vaccine as well. We make a recommendation, with immunocompromised contacts in the household with a healthy baby that needs rotavirus vaccine. We do recommend, and we recommend this for everybody in all circumstances, proper hand hygiene during diaper changes, because there will be rotavirus vaccine virus in the stools of those infants, but with proper hygiene that can be prevented. And then lastly, and this is more of a healthcare provider issue than a family member or household contact issue, but we get this question a lot when healthcare providers are constantly asking us about LAIV vaccine, because they're, of course, in contact with many immunocompromised patients. Can they receive LAIV vaccine? The answer is yes, with one exception. If they are going to round on patients that require care in a protected environment with air exchanges and we're talking about patients that have bone marrow transplants or severe combined immunodeficiency disease, those patients. Those healthcare providers should preferentially receive inactivated influenza vaccine. If they received LAIV, they're probably going to be shedding it for 7 days, so they should not round on those highly immunocompromised patients for a week. So that's the last example I can think of.
All right, last question for today, and as I said, we'll answer the remaining questions received, of which we received many in writing online. It's two related questions. If one gives an expired dose of an inactivated vaccine, the example given was hepatitis A, does one have to wait 6 months to give this is the second dose. Does it have to wait 6 months to give the proper second dose, or can you give it sooner? And the related question was, if you gave the second dose a month early, do you have to wait 6 months to give the proper second dose because you violated the minimum interval?
So the very short answer to that question is you don't have to wait an interval in the first circumstance with the expired vaccine, and you do have to wait an interval with the invalidation that's due to the vaccine being given too early. So these are two very different circumstances and scenarios, and it's really important to tease them apart with vaccines, especially inactivated vaccines. So just taking the second half of that question first, vaccines are given too early when you violate the minimum interval by more than the grace period. It is true that there's no medical scientific reason why you would need to really wait an interval before repeating an inactivated vaccine as long as you gave it at the right time. However, we have programmed a lot of our vaccine accountability computer systems, and a lot of registries are programmed to automatically insert a minimum interval into that repeat dose. And so the second circumstance, if hepatitis A is given if the second dose is given too early, yes, you should wait 6 months to give that that repeat dose, the third dose of hepatitis A vaccine. In the first circumstance with an expired vaccine, you're not going to count the expired vaccine dose, of course, but you don't have to wait an interval to give the repeat dose as long as it's the correct time to give it. There's no, in this circumstance, if you didn't violate a time situation, if it's just an expired dose, you can't count it, of course, and you have to repeat it, but there's no reason why you can't give that dose ASAP.
Thank you very much, Dr. Kroger. That's all the time for questions. Again, we'll answer the remaining questions in writing and put them up online. Let me repeat the CE information. For CE credit, please go to http://www.2a.cdc.gov/TCE online. Search for the live event course number, which is WC2645- today's date 060816. Again, WC2645-060816. CE credit for the live course expires July 11th of 2016. You can search for the Enduring Archive course number, which is different, and that lasts till June 1 of 2018, and that course number is WD as in David 2645-060816. The verification code for both of those is GEN-2016. That's capital G, lowercase en, -2016. For help with the online CE system, which should be easy to use, but occasionally there are problems, please call 1-800-41-TRAIN, TRAIN, or email to ce@cdc.gov. If you have additional questions that you didn't ask on today's program, you may email us at nipinfo@cdc.gov, and one of us will be happy to answer the question. Please indicate the question came from today's net conference or webinar. If you have general immunization questions, you may call 1-800-CDC-INFO between 8 a.m. to 8 p.m. Eastern Time, Monday through Friday. Additional resources are the Pink Book, the Epidemiology, Prevention of Vaccine-Preventable Diseases, at the website you see there online, and this will be online as a resource as well. The CDC Vaccines and Immunization homepage at cdc.gov/vaccines/default.htm, and there is abundant resources listed on that webpage at vaccines/ed/downloads/imz-resources.pdf. We have a Twitter handle at CDCIZLearn. And thank you very much for tuning in today's program. We'll have the next program in the series on general immunization recommendations and vaccine safety next week at noon Eastern Time. Thank you so much from Atlanta, and good day.